Today I'm going to discuss a new topic entitled To Tell the Effect of COVID-19 on Oculoplasty in a Nutshell. I am Mahmoud El-Atta, an assistant lecturer of Oculoplasty, Ophthalmology Department, Tanta University. It's really a good pleasure to me to share in such a great event in our university. The effect of COVID-19 is obvious all over the world, but let's start with some definitions to understand the further meanings. First, what's oculoplasty? Oculoplasty is a peculiar subspecialty of ophthalmology. It's dealing with the diseases of the eyelid and the lacrimal system, the ocular surface, and the orbit. There is two definitions which are intermingled with each other, the emergency and the urgency. The emergency is the state of the immediate threat to life, but here it will be the threat to vision of massive retrobulbar hematoma. While urgency is a state that become emergency after a given period of time. So you have still some period to intervene. And if you not intervene immediately, it's okay, but you must intervene after a while of time, such as in cases of collecting abscess. Of course, COVID-19 has a bad effect all over the world, and also on oculoplasty. It has a bad effect, but there is a hidden aspect which is called the good effect. I can demonstrate briefly here. Let's start with the good effect of the COVID-19 on oculoplasty. It was obvious that when the European Society of Ophthalmic, Plastic and Reconstructive Surgery on May 2020, when it declared a new classification for the emergent cases and the urgent cases, as we see here. Also, the American Academy of Ophthalmology performed the same when she listed a list of urgent and emergent ophthalmic procedures on March 2020. From this point of view, we can demonstrate that the categorization of the procedures and the conditions that occurred for the oculoplasty during the curfew times, such as the pandemic of the COVID-19, requires immediate interventions, and the others can still have time to intervene. I mean, these classifications demonstrate the effect of the oculoplasty and the importance of caring about such cases in order to avoid the hazards such as the visual loss and or deformity. Also, it strengthens the complex structure that's required for the adequate management of the cases that depend on the doctor and the patient and the hospital. Obviously, you need to care for the doctor who is well educated and trained for the different protocols of management of the oculoplastic cases, in addition to the patient who must have a good awareness that in spite of being in a case of curfew, you must deal with your case as an emergency case and seek medical advice. In addition to the hospital, which was facilitated with a lot of facilities for the immediate intervention. This is the good effect. What about the bad effect? The bad effect is the effect which is obvious for all of us. The bad effect was obvious for all of us. This bad effect could be categorized in many of the hazards to us. Let's see why there is bad effect. Because when you have legislations for the movement of the patients, in addition to the fear from this or from the infection, the patients, in spite of the awareness that was pronounced by a lot of propaganda, but still there is lack of adequate awareness. So the patients neglected their cases, and this led to a lot of sequelae. I am going to discuss some of these sequelae by case presentations to be in focus. This case presentations was presented to me at Tanta University, and we are dealing with them to achieve the best result in spite of the presence of these disasters. Let's see. The first case regarding one of the hazards, which is the loss of vision. As we see in these two images, this patient was a 35 years old male patient presented to our emergency department with a history of the left eye plant trauma. He has a negative history for the medical and surgical condition. On examination, we found that the best corrected visual acuity was no BL, and the visual and the pupil was dilated and reactive with limited ocular motility in all directions with left subconjunctival hemorrhage, ecchymosis, and proptosis. The history demonstrated that we must do CT orbit, and the CT orbit demonstrated the presence of left retrobarbar shadowing, suggesting the presence of retrobarbar hematoma. The problem is that the patient, when subjected to the plant trauma, he was subjected to a certain hospital, and the non-specialized doctors just prescribed him medical treatment and asked him to stay at home. because he has no knowledge about how to deal with such cases. But the patient condition progressed and the vision deteriorated more and more, and so the patient came to us. But unfortunately, the vision was lost. At this point, we decided to admit the patient to give him the parenteral treatment and the meticulous follow-up, not for the vision because it's already lost by the default, by the bad management, but for the cosmetic purpose. And as we see, the patient has this result after the adequate treatment. This is first bad sequelae. Second sequelae is the sight-threatening condition. As we see in this image on the right, it was for a 70-year-old female patient presented also to our emergency department at Hunt University. And she has a history of full left lower eyelid surgery for the lid correction since 7 months. On examination, we found a deformed lid with severe corneal stromal necrosis and the iris prolapse. The patient didn't do regular follow-up. Why? Because of the curfew. And when she came to us, of course, the cornea was very bad, so we performed a tectonic graft for this patient and tarsorrhaphy to save vision. Then permanent tarsorrhaphy was done to correct the lid position. As we see in this image, this is the initial tarsorrhaphy, and then final correction of the patient by the medial tarsorrhaphy, and the lid become completely corrected. So if this previous patient wasn't corrected at immediate condition, the patient may have lost her vision as the first patient. Third, amblyopia, which is the diminution of vision without obvious organic cause. In this patient, a 1-year-old female patient presented to our patient clinic with drooping of the upper eyelids, especially the left eye. So when we examined her, she has the complete ptosis of the left eye with mild compensated ptosis of her right eye. Of course, we decided to perform a correction of this patient before the curfew time, but then the patient disappeared, unfortunately. And when she came to us after a very long period of time, we decided to immediately perform a sling to correct this patient in order to avoid amblyopia. And as we see here in the image, the patient became corrected and we saved her vision, which may be lost if we delayed this intervention more and more. The fourth sequelae, or fourth bad effect, is the vital structures infection. As we see here, the patient has a corneal ulcer and red irritated eye. This is a case of 44-year-old female patient presented to our emergency department with right irritated red eye. When we examined here, there is right hypopian corneal ulcer with restricted ocular motility because of the presence of upper eyelid symplepharon. The patient neglected symplepharon and the infection occurred, and then when she came to us, she admitted to cut the symplepharon and do AMT fixation and then tarsorrhaphy. Then tectonic graft was performed for this patient and retarsorrhaphy. As we see in the image above, the hypopian is obvious, and we did the amniotic membrane graft. Also, we cut the tarsorrhaphy, we cut the symplepharon, and we performed the tarsorrhaphy for the patient and the tectonic graft. So we saved her eye. Fifth bad sequelae is unexplained cataract. As we see in this patient is 64 years old male patient presented to our outpatient clinic with disfigurement of the right lower eyelid. When we examined him, he had a necrotic invasive lesion. Mostly is basal carcinoma, necrotic floor, rolled in edges. So mostly basal cell carcinoma, and especially is the presence of this site and this age. So his operation was done for him. As we see, this is the patient after the operation, after the excision of the tumor and doing the grafting. The patient disappeared. It's supposed that when this patient performed such a condition, we perform the splitting of the lid after 1 month. But unfortunately, the patient delayed for 10 months because of the curfew. When the patient returned back to us and we performed the opening, we found a total cataract and the patient said, I can see. We can't explain why this cataract has happened. Maybe because of the prolonged occlusion or maybe because of the steroid eye drops. We can't know. But only things that we know that if the patient came to us earlier, the patient may not have this picture of cataract. Sixth type of the complications or the bad sequelae is a tissue deformity. As we see, this patient is 37 years old, male patient presented to our emergency department by road traffic accident. As you see in the image, the patient has a lot of multiple wounds in the face and the lid on the right side, and performed perfect suturing as we see in the right image. But unfortunately, the patient disappeared because of the curfew time and then returned to us in this bad picture. The wound became infected, necrotic, with a sloughs tissue, as we see in this image. So we decided to perform a tarsorrhaphy for the patient till mature scar is performed and then performing correction. The images on the right side is after we did the full red reconstruction by using grafting from the post-auricular area, as we see on the opening and on the closure, and we saved the eye of the patient in addition to the cosmetic appearance. Seventh is recent condition, the missing of the foreign body by a non-specialized doctor. As we see, this 12 years old male child presented to our outpatient clinic with a history of trauma by a woody object 4 months ago. The patient has a right lower lid wound that has been sutured. When we took a history from this patient, the patient was subjected to the trauma and went to a general hospital. The doctor closed the wound without searching for something foreign and something different. And then the patient returned back to the doctor, but the doctor said to him, your condition is okay and there is no problem. But when he came to us, there is a right lower leg granuloma inside an open wound at the nasal part of it with whole lower eyelid edema. When we performed a CT, there is nothing in CT, and this raised my suspicion because presence of granuloma, in addition to the edema, in addition to the absence of any foreign bodies present in the CT, suggests the presence of something woody that inside this granuloma. So I decided immediately to subject the patient to the exploration of the wound under the general anesthesia, and I found a woody foreign body as I expected and removed it together with the granuloma. As we see, the woody foreign body was passing tangential to the lacrimal sac. I removed it and the wound is closed and now it's under healing. To take a home message from this presentation, first, emergent evaluation, immediate management to avoid the permanent damage and visual loss. Second, during critical times such as COVID pandemic, adequate determination of which cases require emergent intervention is a must, even in presence of the fatal virus. Third, the emergency control is a complex structure, including the doctor, the hospital, and the patient. It's not a one-man task. You must have a well-trained doctor to deal with the different conditions, especially at such critical times, because you have no time to ask for a new expert to come to us because there is restrictions, legislations for the movement. So the doctor, the other doctor can't come, may in sometimes. So you must train you must have a well-trained doctor at your hospital. In addition to the availability of the equipment at your hospital for immediate intervention, such as in cases of the retrobulbar hematoma, in order to save the vision of the patient, and also awareness of the patient. If the patient has a very important rule. If the patient has no awareness, he may neglect his case, as we see in many cases of bad sequelae, and this leads to further disasters. Fourth, jack of all trades, master of none. It's an old proverb, which means there is nothing in ophthalmology called a general ophthalmologist. Now there is a subspecialty, also there is a subspecialty. Even in our subspecialty, which is oculoplasty, there is a different subspecialty. Some is one subspecialized in the lid, and the other in the lacrimal, the orbit, and so on. So there is nothing called I am a doctor who can deal with everything. You must refer the case to the one who is subjected. But what about the emergency? You must train your trainee at the emergency about the general protocols of dealing with the emergency cases in order to avoid the hazards, and then refer your case to the prof and to avoid further damage. Thank you very much, and there is my contact information for any further inquiries. Thank you.